Good afternoon, everyone, and a very warm welcome back to the Member Showcase session on risk management in systems. I'm Salman Desai, Director of Strategy, Partnerships and Transformation with the North West Ambulance Service, and I'll be your chair. Over the course of the next 45 minutes, we will provide details of 2 case studies from 2 trusts who have found imaginative and effective ways to manage risk whilst working with partners. The first of this will be Trish Bennett, Deputy Chief Executive of Clinical Services and Chief Nurse for Mersey NHS Foundation Trust, and she'll be talking about safe and timely patient flow. Then we have Satbinder Sanghera, Deputy Director for the South London Partnership, and he's joined by Paul Hunt, Interim Head of Contract Mobilisation. And they'll be taking us through a new approach to collaborating to improve mental health services. What we'll be doing, we'll be showing a short animation video followed by a brief presentation from each of the speakers. And what we're hoping to do at the end of the presentation, we'll have a Q&A. So please start sending your questions as they come up, which I'll put to the panel later. So, can we play the first video, please?
Mersey NHS Foundation Trust needed to develop a system-wide approach with Liverpool University Hospitals Foundation Trust, Liverpool and Sefton CCG, Southport and Ormskirk NHS Trust, and Liverpool and Sefton local authorities to manage the risk of safe and timely patient flow throughout the 4th wave of the pandemic. To do this, they needed to change their focus from operational to one of patient safety. This meant that while patients were waiting for transfers to other services, potential harm was minimised, and patients were treated individually and with respect and care. A weekly executive system safety huddle consisting of system executive leads was set up to manage urgent care demand, manage a consistent set of risks in a dynamic manner, workforce challenges and deployment, capacity and flow processes, and visibility of all right to reside patients. The change in approach meant that knowledge and understanding of the reasons for delays across different pathways was increased, and as such, there have been reductions in patients waiting over 72 hours in acute beds after criteria to reside was not met. The initiative improved patient experience, safety, health and well-being of staff, and health outcomes, and the system has already agreed its winter plan priorities for 2022-23.
Oh, thank you, Trish. Do you want to take us through your presentation?
Good afternoon, everybody. Thank you for the opportunity today to describe to you our collaborative approach to addressing underlying challenges and in a very systematic, sustainable way in terms of improving safe and timely patient flow and therefore valuing patients' time. Could I have the next slide, please? And the next one, please. So what we'll cover today, first of all, I will do some introduction and background to why, how we've developed our priorities for winter 22-23 across our system. What do our system risks look like? How are they managed and how are they mitigated against and how are they owned by our partners? What the executive safety huddle actually looks at, what happens at the executive safety huddle that's different, and how is it embedded in our governance, our system governance, our individual organisational governance, and how we use this process to learn. Next slide, please. So in terms of introductions and background to this, North Mersey the footprint consists of Liverpool, Sefton, with hospitals such as Liverpool University Hospital, Southport and Ormskirk Trust, Merseycare, local authorities, CCGs, etc. There has a standard A&E delivery board. Those arrangements are there like they are in the rest of the country to help monitor, deliver and make decisions about the urgent care system. To plan for winter, to plan for incidents, look at performance, typically look at performance, focus on delays, both at an individual level and across the patch. We felt in this system in North Mersey that there was definitely a gap that needed to be fulfilled, and it was a system executive decision to introduce a executive safety huddle process. And we did that in December 2021. That was the first commencement of the executive safety huddle. It was very much about assessing a different tone, a different approach to performance and delay, to look behind those numbers and to understand what's happening to our people and the people that we serve. It was absolutely a mindset change, a real cultural change from all the organisations, where we would often look at packages of care delays, bed capacity delays, some organisation was responsible for. We're actually moving very much to what happens to people when these things happen in the system. We use the executive safety huddle to unblock immediate challenges. So you have executives from all those organisations around the table. It's a place to escalate and learn, and to feedback to clinicians, to managers, and for them to be able to escalate too. It's about leading from the top and taking responsibility. It's about affecting those who are on the frontline services. That executive membership across health and social care is very visible to them, and they know that this is a place where they can talk about patient safety. As I said, setting a new culture, not moving away from numbers, not moving away from data, which is extremely important, of course, but actually looking behind that, and a culture of valuing patients, service users, people's time. To look through the patient safety lens at all of this, and looking at the potential harm lens, and obviously together, collectively and collaboratively, making sure those mitigations are in place and owned and learned from. And to understand, as I've said, to address the learning themes that we are starting to see as a system leadership group. Next slide, please. So, as I said, that happened earlier on, before around December time. So what happened after that, after we got through this was a very initial busy winter period, we've moved then to really putting together this systematically and moving into a different stage. And if I could have the next slide, please. We have actually moved to developing key priorities for this coming winter, to make sure that we have acted on mitigations and we have identified the key risks that are being managed by the system. We have in place an approach and governance structure that can be used to drive this forward. We have a system improvement board, and we have identified across all of our organisations single senior responsible officer for the key priorities, which I'll come on to as we move forward on the presentation. If I could have the next slide, please. So what you can see here is the system focus and the priorities that I have just mentioned. Let me start first with the 4 identified system risks. Firstly, urgent care demand. Secondly, workforce. The third, capacity, flow and processes. And the 4th, data. Those risks are owned by the individual organisations and overseen through their own assurance process, but collectively through the executive safety huddle process as a system. The risks are mitigated, but the drive is the 3 drivers that you can see in green. So the improvement drivers and where we expect to have the biggest impact through this process is admission avoidance, to make sure we optimise bed occupancy, and secondly, ED attendance management, stopping unnecessary patients present at ED, and thirdly, improve capacity and flow and a reduction in ready for discharge numbers of right to reside. The mitigations that you can see in the middle have come from our review of risks, our learning from our planning, our escalation, the data that we're seeing through our impact drivers and the improvement process. And we have now on a page 10 areas where our priorities, where we are developing sustainable, systematic change plans for our coming winter. We consider at every point what is the potential harm, how can we mitigate against that, how do we value patients' time, and that is the currency that actually we all understand. So we talk, as I say, beds, packages of care, delays, etc. And it's always has been some part of the system who has that responsibility. When you talk about what happens to people and their time, it's been a currency and a shift in approach that has actually brought us all together. Next slide, please. So these are the risks, just to show you in further detail, that have been managed and identified. But what you can see here with the red dots around is the potential harm for each one of those, signed up by all the partners in the system, identified in terms of whether you're in the local authority or you're in the acute trust or you're in a mental health trust or you are a commissioner. That is the potential harm that's identified. The risks are developed in order to mitigate against those. A different way of looking at this. Next slide, please. So practically, you know, in a terms of practical perspective, what does the executive system model look like? Again, if you could move on, please. So as I say, we do not veer from the 3 impact drivers. Everything that we look at is via this process: admission avoidance, ED attendance, criteria to reside. We look at weekly data, but we look, as you can see, hopefully on this screen, the trend data. And out of that, deep dives will happen. There'll be areas that clearly from looking at the data, but also the evidence that we gather around patient experience, we will do some deep dives and improvement. And again, if I could move on to the next slide, please. So this is one of them. You can see in terms of data, we are seeing some increase in 72-hour delay reasons. We've broken each pathway down into phases of what those delays will be, you know, so 1 to 5 you see at the bottom. Delays that can happen in pathway 1, pathway 2, pathway 3, and broken down to phases. This information here, this is a snapshot of what we would look at. So at this point, the most common phase for patients waiting more than 72 hours was in phase 3, across all the pathways and across all CCGs, so across all our areas. Pathway 1 relating to packages of care. Those in pathway 3 awaiting decisions from external agencies. To give you an example of the snapshot and the information that we look at and the detail that we would look into. Again, if we could move on, please. So in terms of a deep dive and the data that we're looking at, we have just recently looked at delays in fast track, so end of life. Patients who want to express the need to be cared for at home in the end of life phase, and the delays that we've seen. And we have seen some delays. I need to stress at this point that there is no question about the care that's been given to our patients in terms of the last few days of their life, but it was given in the wrong place. We have not valued their time enough because we've allowed these delays to happen. We've already highlighted this. This has come through our data. There's an improvement plan in place. We've actually started to see those improvements happen. But the approach that we took is, what's happening to these people? What's happening to the time? Are we valuing their time enough? And that was a collective, systemic system response from all the organisations. Next slide, please. This just gives you an example of where we've moved to. So we, as an ED board, as an A&E board, we would be looking at plans for bank holiday, pressured times in the system, Jubilee coming up, all of the things that you would expect to happen. You expect a good system to be preparing for, planning for, working together on, and that does happen. But what we are pushing through the executive safety huddle is that those plans are tested through the patient safety lens, through the value in patients' time, through the avoidance of harm lens at every point. That actually after the process, when we've got through the difficult escalation period, that we learn, we review, we look at sustainable change, we make decisions about where best to put our efforts in a time when resource and workforce resource is so precious and so challenged. Then actually learning sustainably as a system about where we put our efforts, how we make those decisions. The executive safety huddle will review that process and has that discipline of doing that, and will continue to do that over the period of time. Next slide, please. So just a bit on the governance and the learning and where this sits. And if I could move on again, please, I will hopefully demonstrate to you the governance arrangements. So you can see at the top, the A&E board, it reports into, actually, we have an integrated partnership board reporting into the ICS here. You can see the executive safety huddle directly reporting into the A&E board, and a series of governance meetings that happen that escalate into the executive safety huddle with issues, with areas of concern, with pressure, with areas that we know need improvement, and we will look at that as an executive team on a fortnightly basis. Thank you. If we could move on, please. So go back to the risk, and it's a very dynamic approach that we would see at the safety huddle. We report into this fortnightly, as I've said. And as you can see, in the four risk areas, we have recently looked at, for instance, data challenges with our right to reside process, how that is affecting the criteria. That's a challenge. Does it affect our risk? The new testing arrangements, when they happened in terms of COVID into nursing homes and residential, how did that affect our capacity and flow risk, etc.? The pressure, the occupancy in intermediate care beds was reaching up to 150%. How did that affect the risk and the scoring and the mitigations that we're managing? Just an example of how dynamic this is, how we work together as executives and leaders across the system to do that. Next slide, please. This is the agenda. It drives our approach. We have regular updates and conversations and discussions that are framed around our risks, increasing or decreasing, clear escalation, clear de-escalation, escalations framed around our system risk. All the agendas ask ourselves the questions that I've outlined. Thank you. And next slide, please. We're coming to the end of my presentation and where we're moving to. So we look at ready for discharge, right to reside, very negative language. We move to valuing patients' time, very positive language, and a language that all of our organisations get and understand. We have just this week, on Monday just gone, had a big seminar across the system where we focused on the last 1,000 days of a patient's life agreed a framework how we will take this forward in terms of our potential harm approach, the language that we're using in our priorities. We think this is an approach that will be part of a big change movement in the system. It aligns with the improvement work in Liverpool University Hospital, and actually in all of our organisations that are bought into our executive safety huddle approach. And that's the dynamic movement and the commitment that we're seeing across the system. I think I'll stop there, please.
Thank you very much, Trish. A really interesting presentation and approach to patient flow that I'm sure many systems will be grappling with. Can we play the next video, please?
The South London Partnership is made up of 3 mental health trusts: Oxley, South London and Maudsley, and South West London and St George's, who have come together to address the health inequalities and variable access to mental health services in South London. In order to be successful, the partnership agreed on the service's priorities, establishing frameworks to align the trust's shared goals, balanced with their individual scopes of care. Additionally, to mitigate any potential conflicts, they focused on building trust and shared leadership across providers. The combination of their clinical expertise allowed them to increase their understanding of patient experience, transform outcomes, improve quality of care and the financial sustainability of services, and ultimately improve the quality of mental health services in South London. Working together as the South London Partnership and bringing together each trust's expertise has been beneficial to patients, service users, carers and their families, extending out into the community with areas of collaboration, including NHS England-funded specialised mental health services and CCG ICS-funded complex care.
Thank you. At Satbinder, can I invite you just to give us your presentation?
Okay, thank you. Good afternoon, everyone. Can I have the first slide, please? And can you go on to the next slide? So just to set out, by way of introduction, the partnership's been going actually since 2017. So it's been in place now for over 5 years. And it's a strong, successful partnership, I think, as the VT set out. My colleague Paul will give you the evidence to kind of back that up and the examples to be able to demonstrate how successful we've been in terms of patient outcomes and in terms of improving the quality of services. I will go through essentially how we've managed to kind of build trust and then how we've used our governance and risk arrangements to support the partnership further. And I think it's important to kind of set out from the start. We've got 3 provider collaboratives for CAMS, adult eating disorders and adult secure. But we've also got other programs of work, such as complex care and the nursing development program and the acute care program of work. And they are testimony to the fact that we have made significant strides as a partnership. You don't need me to tell you that there are no shortcuts to partnership at all. It takes time, and we've had 5 years to develop those relationships and develop the, if you like, the softer and the harder mechanisms to be able to build that trust. And initially, that trust was based on an understanding that we would only collaborate in areas of work where there was clear, rational and demonstrable benefits of working together. We've never tried to work on areas where we have not been able to identify the very clear benefits from a kind of quality perspective or improving patient outcomes or through achieving economies or efficiencies. And where we've recognized that there's an area or an opportunity for us to exploit to be able to grow. So identifying the clear benefits from the start. It's also really important to set out that people don't feel threatened or challenged by the South London Partnership. So we've always made a point of saying the South London Partnership is not a legal entity. We have 3 sovereign trusts. The partnership are the trusts and the trusts are the partnership. And we've always made sure that that message has been hammered home on every single occasion. It's important, otherwise the partnership wouldn't work and we wouldn't have the trust of the people who work in those trusts. It's also been important for us to be clinically led, because we need to be able to prove to everyone who works in the trust that the South London Partnership, again, is not something to be feared or to be threatened by, or is a prelude to 3 organisations merging or anything like that. But it's important to demonstrate that we're coming from the perspective of being clinically led. So all our programmes of work are led by a clinical director. And you can, and the way that we've then been able to kind of build that, can you go on to the next slide, please? The way that we then go on to that is by developing some kind of key mechanisms to emphasize the point around partnerships and trust. So if you go on to the next slide, please. So something key for us has been around 2 key developments over the course of the kind of last year or so. So one has been the assurance framework. So this is an assurance framework that is considered at the portfolio board, which is where the executive teams of the 3 trusts come together with people like myself from the South London Partnership, and also the partnership committees in common, which comprises of the 3 chairs of the 3 trusts, non-executive representatives from the 3 trusts, and the chief executives from the 3 trusts. And the assurance framework, therefore, is a high-level strategic document, which is obviously mapped on our strategic priorities and sets out clearly the kind of key risks and challenges to the SLP in achieving its goals and ambitions. But underneath that sits risk registers for all our programs of work. And that's incredibly important because it's part of the process of the 3 trusts sharing and learning the risks from their kind of perspective. Therefore, there's a level of transparency and openness, and therefore some challenge, and also being willing to actually understand that another trust may be doing things better and to adopt that approach themselves. And it also then allows us to put together the kind of key mitigations from an SLP perspective. The second key area of work that we've developed over the last year is around our planning priorities and our commissioning intentions. So last year, for the first time ever in the South London Partnership, we decided to adopt the commissioning cycle and develop commissioning intentions, which initially came from the clinicians themselves and from our partners and from our patients. And we started developing priorities for all our kind of programs of work. And then as we went through the process, prioritize those intentions further to identify the key areas where we would like to make investments. And that was a decision that starts from the bottom but works its way through the top through to the partnership committees in common. And that's incredibly important because it shows, again, a level of transparency and allows all the kind of key individuals from the 3 trusts to be involved in setting the priorities and deciding where the investments should be made for the future. Go on to the next slide, please. As I've set out, we have got our portfolio board and our partnership committees in common, which and our program partnership groups. And it's important to say that for all 3 of those layers, no decision can be made without the agreement of all 3 partners. A trust, no meeting can be held without all 3 trusts being present. And this is something that goes right through every aspect of our decision making, no matter how big or small, whatever meeting it is, we make a point of ensuring that all three trusts are represented. And therefore, it is important, therefore, that that all three trusts hear kind of the work as it's developing, the progress we're making, all at the same time. And that's incredibly important in terms of, again, reinforcing trust and the partnership way of working. I'm now going to hand over to Paul, who will take you through some of our key achievements.
Thank you very much, Satbinder, and good afternoon, everybody. What Satbinder set out around trust, governance, and risk management are not ends in themselves, but have an end in better experience for our patients from South London, and also those who access services within our geography. And we believe we've made substantial change within the three provider collaboratives that Satbinder described: CAMS, adult eating disorders, and adult secure, but also in some non-provider collaborative programs, particularly complex care, nursing development, and acute care. The thread across all of these programs is care closer to home in some way or another, often through coordinated bed management, where the three trusts work together on admissions rather than independently. And that's enabled us to develop a number of local services, often community-based services, but also some inpatient and some community-based residential services. We've, throughout the 5 years, had service user and care involvement, and we're continuing to strengthen that as we go forward. And the changes that we've delivered, and I've referred to two or three of those in a moment, the changes that we've delivered are giving confidence for us to look at developing new programs, and specifically looking at a provider collaborative for each of our ICSs around specialist mental health care, and also across South London collaborative approach for specialised perinatal mental health care. We have enabled over 200 people to step down into less restrictive settings, which is a key national driver, but also one that we know affords our patients greater dignity and respect, and leads to improved outcomes. The pathways have been led by our clinical directors, and that's enabled us to secure agreement across our three partners as to what services we need in order to enable that step down. We've reduced out-of-area placements. In the past, a lot of South London patients were scattered in units across the whole of England, often hundreds of miles away from their homes, their families, and their networks. Not only does that isolate patients, but it makes it very difficult for our case managers who oversee their packages of care, very difficult for our case managers to look at the quality of the services they're receiving, and to ensure that the best possible services are being delivered. It makes it very difficult when a patient is 100 or 200 miles away from home for them to be discharged into community pathways. And that's led to much increased length of stay and an increase in inappropriate restrictive settings. Through the partnership approach that we've implemented, we've been able significantly to reduce the number of out-of-area placements. For example, in adult secure services, over a 5-year period, we repatriated, brought back into South London over 150 patients. Within CAMS, we managed over 2 years to reduce by almost half the number of non-South London partnership occupied bed days. And in adult eating disorder and our CAMS services, it is now extremely rare for us ever to place a patient outside of South London. And when we do need to do so, it's very common for them to be also repatriated very quickly back into South London. The partnership approach has enabled us, as Satbinder was saying, to develop our commissioning intentions, and those intentions are driving our review of a succession of business cases, which particularly look to build community provision. So we're, and every decision that we make on a business case has the full support of each of the 3 trust partners. So there's never a focus on a business case that might favour one partner over another. And so we're looking at a number of cases at the moment, or implementing a number of cases at the moment, which will particularly address health inequalities. Looking at, we've implemented a community hospital for women. We've implemented community forensic support for Black and minority ethnic men. We are looking to increase our learning disability and autism forensic provision. We have implemented a set of outreach teams, DBT teams, and intensive outreach teams within CAMS, and outreach and in-reach teams within adult eating disorders. So we've a number of things that we've delivered already, a number of proposals that we're actively considering now, and through the savings that we've achieved, we're able to fund those investments and so improve the quality of outcomes for our population. Thank you very much. Hand you back now.
Thank you, Paul. Thank you, Satbinder. I think what we'll do is that in the interest of time, we'll quickly move on to the Q&A, because a couple of questions have already come in. Trish, you're joined with Maggie Oldham, so I'll come to you first. And the question is, what has been the most impactful action for Impact Driver 2, and what has the data shown what will bring the biggest impact in the next 12 months?
Maggie, do you want to respond? So in terms of the ED attendance, in terms of the biggest impact, it's really actually getting the data right, getting the correct data in place in terms of support and flow from the ED into other parts of the system, both in terms of redirection, but also into the right place into provision.
Trish, the question goes on to ask, they were particularly interested in, what were the actions for primary care, community care and social care in this, yes, given it's fairly critical to the flow of the system, isn't it?
Yes, so very, very importantly was the highlight around 7-day provision and availability, both within the hospital organisations, but also within community and mental health services. Just to say that the data that we look at does look at mental health also. It references around, particularly around A&E liaison, for instance. So one of the big issues that came through was the availability of 7-day-a-week provision, either going in or preventing admission and attendance, and making sure that was consistent from all the organisations, from social care, from community and mental health, availability through the organisation itself, so that the flow could be maintained. We saw very quickly that actually all the work that was happening in terms of discharge, really positive work, reaching the ambition Monday to Friday. And then what we'd see at the weekend was admissions going up, discharges coming down, and actually go back in on the Monday morning, and we were almost back to square one. And we've seen it in busy times, preparing for Christmas periods, for instance. We were creating a lot of capacity in the system. By New Year's Eve, we were back to where we were. And that's not to decry in any way the hard work that goes on across the system, but not really understanding what that sustainable change could look like, one of the big things that we've seen happen, and we've started to turn this round in terms of attendances, is to make sure that what we provide is 7-day, that we have the right redirection tool in place, and we also have the right services to respond to that. So they were two big areas.
Okay, thank you. Maggie, I wonder if I can come to you. The question that Diane poses is that how do the various organisations within their system capture the risks that you talked about?
Thank you. So all the organisations capture their risks individually. Those risks are also captured through the A&E Delivery Board, and the pertinent ones are also captured now through the Executive Safety Huddle. We're also a system that has, as Liverpool University Hospital Trust is in SOF 4, has a System Improvement Board, and myself and Trish take those risks to the System Improvement Board as well. What is really helpful is to see the consistency of those risks across the breadth of the system, as opposed to just seeing them in individual organisations.
Okay, thank you very much, Maggie. Satbinder, can I come to you? I think one of the other questions that we've had is how involved have the trust company secretaries been in establishing shared governance and risk management structures across the different organisations? Now, I don't know whether it's you or Paul that briefly wants to attempt to answer.
I can answer that one. So the trust secretaries they initially established the governance arrangements for the SLP. So you've got to remember that when the South London Partnership first started, there was hardly anybody working in the South London Partnership. So a lot of the work was reliant on the 3 trusts to kind of get up and running. And it was the 3 trust secretaries that established the initial kind of governance framework and the terms of reference for all the kind of key bodies. As we've developed, I now meet the 3 trust secretaries on a monthly basis for us to review and consider, and also to kind of follow through again in our partnership approach to keep all 3 trusts up to date in terms of the work that we are trying to progress with from a kind of governance perspective. So we now have those meetings every month.
Okay, and just to follow on, how are you assessing the effectiveness of the relationships, the systems, the structures that you referred to within your presentation?
So I think some of it's about our ability to mobilise kind of key programmes of work, and how quickly we are able to see the kind of realised or the anticipated benefits of our programmes, because I think that demonstrates how well we are connected to the workforce within each trust. And then there's kind of softer measures. So, for example, we've just had a session on Friday where we invited the kind of top tiers of staff from the 3 trusts to attend an away day around how the SLP will work within the new integrated care arrangements. And that event was attended by 70 people, which comprises of the kind of leadership teams from the 3 trusts. Now, I think that's a good kind of demonstration in terms of the commitment that we've got from the 3 trusts and their willingness to kind of be involved. And I think it also plays itself out in terms of when we are, for example, looking at risk and looking at the challenges that particular trusts are having, their willingness to share that and discuss that with their colleagues from what were previously competitors, and now they see as partners.
Okay, thank you very much. So in the last sort of 50 seconds, it just remains for me to just thank Satbinder, Trish, Maggie, Paul for their presentation. I think some of the things that we've heard has been that at the centre of both these case studies is around strong leadership. It's about trust. It's about openness to mindset and cultural shift, but also being open to unblock and challenge some of the things. I think what we heard from Satbinder was that actually you do need some of that in place before you progress, but the shared purpose and sharing of risk has to be at the centre of it. So thank you very much to everyone, and thank you for joining us today for this session.